Okay, hi everyone. Thank you for joining us for today's tutorial. Sorry for the slight delay. Today's tutorial is a histopathology tutorial given by Dr. Preethi. Just a few rules. For those of you watching via the Zoom, any questions or comments for things that are relevant to what's being covered in the moment during the tutorial, just pop them into the chat. Any questions that can wait till the end, pop them into the Q&A. If you're watching on the Facebook live stream, just comment your questions and we'll pass them on to the tutor. That's all from me, and I'll hand over to Dr. Preethi now. Thank you.
Thank you. So my name's Dr. Gopinath. I'm a consultant histopathologist and foundation training program director in Harlow in Essex, so Princess Alexandra Hospital. And I'm going to speak to you today about grade and stage, so talking about TNM and the practical aspects of TNM for clinical practice. So hopefully all of heard of TNM during your first few years, and I'm just going to go through the learning objectives. So first of all, I want to just take you through the role of the histopathologist in patient diagnosis, because I appreciate that not all of you would have had exposure to a histopathologist in terms of you might have had someone lecturing you, but in terms of seeing what they do as a day-to-day, you might not be aware. So wanted to clarify that with you, and then talk about the definitions and differences between grade and stage, which is really important to understand, and also to talk about TNM and the basic principles of that. So if we first of all start talking about the role of the pathologist, and this is particularly in the setting of cancer and the MDT, but just broadly, if I go on to this, so we've got a question here. If I can hopefully figure this out. So, right, so pathology is involved in what percentage of diagnoses in the NHS? So got about a few more people voting. Okay. I close that now. So if we look at that, so most of you thought 80%. It's close. It's 70%. This is the correct answer. I don't know why that's highlighted as red, but yes, so the correct answer is 70%, and so 70% of all diagnoses in the NHS involves pathology. Now obviously that includes blood sciences, chemical pathology, microbiology, and histopathology, amongst many others. So that's why that's such a high percentage. So if we move on just briefly about pathology, it includes a lot of different specialties. You can see you've got all of these 19 different specialties, of which histopathology is one. And yeah, so there's lots of other areas in pathology, and broadly speaking, if you have an operation, surgeon removes some tissue, they'll send it to the pathologist for examination under the microscope and also to the naked eye. This is one of my colleagues in the laboratory examining a mastectomy specimen. And so we are involved in many aspects of patients' healthcare and diagnose disease happening in pretty much every organ in the body, and also involved in screening. So approximately 20 million histology slides are examined every year, and we also use special stains to identify infective organisms such as Zeal-Nielsen, Grocott stain for fungal organisms. And histopathologists are doctors. They all undergo training, so 5 years after foundation, so after F2, it's a 5-year run-through program. And then if you get through your exams, and then you can start as a consultant at that point. So it's a relatively short training program. And this is just talking about all the different roles of histopathologists. So got diagnosis in terms of FNA, so fine needle aspiration. So particularly in the thyroid, where you might have a dominant nodule in the thyroid. You would stick a needle in that under ultrasound guidance, aspirate some cells, smear them onto a slide, and then spray some fixative, and then we would stain it with the appropriate stains and then look at it under the microscope to give a diagnosis. And then more advanced from that is taking a core biopsy, where you obviously take a bit more tissue, and we would process that slightly differently, and then obviously removing, so if you were to remove a lobe of the thyroid, for example. And what do? We look at how the cells look like. So do they look benign or malignant, broadly speaking, but also other aspects of benign disease rather than just normal or abnormal. There's a whole spectrum of pathological entities that underpin the whole of medicine. And then in particular related to cancer, we look at the type of cancer, the grade, the stage, which we'll come on to, and then looking at, we can potentially help with where a tumour has arisen from. So if someone has metastatic disease and the disease is spread everywhere, they might do a biopsy, and then we would be able to do immunohistochemistry and special tests to determine where that tumour might have originated from. So that then can help the oncologist to decide what type of treatment they may benefit from. And then the other thing is we can look at causative agents. So this is a microscopic image highlighting this. This is I don't know if any of you know what this is, but this is an asbestos body, or several asbestos bodies. They've got this beading effect, blue in color. And so this is picked up on autopsy, actually, someone who had mesothelioma, and we examined the lungs and got these asbestos bodies, which is demonstrating the causative agent in that case. And that can be very important, because our confirmation of that means that the family can get compensation if it's related to an occupation. And then molecular profiling, so that's also important for a lot of cancers which rely on the molecular test to determine treatment. This is a bit blurred, but basically cytology, as I said, you have the slide, take a smear, a swab of it, spread it on the slide and spray fixative. And that's the principle of cervical cytology. And this is your normal squamous cells in the cytology smear. And then this you can see is different. You've got these larger nuclei. The ratio of the nucleus to the cytoplasm is more in comparison to this one. And the nuclei look very abnormal. They're not really nice and even. The chromatin's not even like here. So that's that. So as an example, breast cancer diagnosis. Now I'm lead for breast pathology in our department, so I'm involved in breast screening as well as symptomatic diagnosis. So if someone has a screening mammogram where they get have a lesion picked up, or they feel a lump, and they would go to the doctor, would refer them into breast clinic, and then they would have a mammogram, an ultrasound, and if they found a lesion, they would then either do a fine needle aspiration, or they would do a biopsy, which is the usual practice to do a biopsy. We would then examine that. So that's the core biopsy there. And then we would process that. So This is just an example. This is not anything to do with the breast. It's an appendix, but it's just an example to demonstrate what actually the process we cover. So the appendix, as it's removed, so I don't know how many of you have had your appendix out, probably a few of you. The appendix, as it's removed, this is the area where the surgeon has tied it off to separate it from the rest of the bowel. And this one is pretty normal looking. This one is pretty inflamed. It's very red. It's got this kind of purulent exudate on the surface over here as well. So this looks like an inflamed appendix. And this would obviously be put in formalin as we receive it, so that the formalin can penetrate the tissues and fix the tissues, so that it takes a snapshot in time of what the tissues look like under the microscope. If you didn't put it in formalin, the specimen would just degrade and autolyse and become necrotic, and you wouldn't be able to make any diagnosis from it. So what we do is we look at basically the appearances of the appendix, and we note any exudate or perforation, and we measure it, and then we would take samples. So particularly in the tip of the appendix, we would take a longitudinal section of the appendix, and then transverse sections along the rest of it. So this is the tip, so we take a longitudinal section here. And the reason for that is because a lot of the pathology in the appendix, such as carcinoid neuroendocrine tumours, now called neuroendocrine tumours of the appendix, quite commonly in the tip of the appendix. So that's the reason why we sample it that way. And sometimes parasites can hide in the lumen. So this is where this section becomes useful. So sorry about that. So we would put this into cassettes, and then those cassettes, those pieces get processed, where the water gets removed and replaced with xylene alcohol fixative. And then those pieces of tissue get embedded into paraffin wax, and then it comes out like a block like this. And this is where the pieces of tissue are set in position. And then the block is trimmed, so you get very fine 4-micron thick paraffin sections, which are then placed onto a water bath to disperse them, and then they get picked up with the slide. And this is all done by technical, highly experienced, skilled technical staff. And then those slides are then stained with hematoxin and eosin, and these are all automated processes now, but obviously if it's a cytology slide, for example, it might be hand stained, and then we look at it under the microscope. So that's a broad process. So this is a fine needle aspiration. Yeah, so this is a fine needle aspiration of a breast sample. So someone's put a needle into a lesion, aspirated some cells and put it on a slide. So this is effectively a benign aspirate. And this is what this would look like under the microscope if you took a biopsy, because that's the difference. So you look at histology and cytology. So histology being the tissue and cytology being the cells. So if we talk about breast cancer, this is how a tumor looks like if they've had it removed, a lumpectomy or mastectomy. And you can see that there's a stellate white area that's occupying the breast. This would be what normal breast looks like, because it's very fatty, and then overlying skin there. And under the microscope, this is an example of DCIS, so ductal carcinoma in situ. And this is a pre-invasive type where it hasn't actually extended and become invasive. That is, so that's the type of DCIS. And then it progresses, or you might find an area of invasion. So this is an invasive tumor. And then this is another type of breast cancer, but you can see there's over 20 to 30 different types of breast cancer. So when you say you've got breast cancer, each of those tumor types has different prognosis and associated with different risk factors. So So it's not just enough to say the person's got breast cancer, you need to say what type of breast cancer they have, so that can guide management and prognosis. So an example of colorectal cancer, for example, this is what this would look like under the microscope. You've got kind of gland formation here, and you've got this central necrosis, which is typical of what colorectal cancer looks like. And this is what it would look like in the bowel when we open up the bowel to examine it. So the naked eye observation, the gross observation of specimens is really important as well, because it's all very well having a large piece of bowel, but you need to know where to take the blocks from so that you can get the right area to look at under the microscope. So observational skills are really important. And this is a liver section or piece of liver which has got extensive metastatic deposits. You can see largest one there and there, and they got this necrotic appearance. So there's dotted through, and this kind of demonstrates why patients with metastatic disease might get abdominal pain, because the metastases tend to be subcapsular and they stretch the capsule. And that's why you get that liver tenderness when you examine an abdominal pain in someone with metastatic disease. Lung cancer, so this is a normal respiratory type epithelium. So you've got the cilia up here at the surface, and then you've got a nice orderly line of cells here. So that all looks fine. And then if someone's taken done a bronchoscopy where they've put camera into the bronchus and then aspirated some fluid or taken some brushings from it, then that might show some cells, and these cells look malignant squamous cells. I think someone's put their hand up. So are you able to speak or chat, write something in the chat? Okay, well, hopefully connect later on to ask a question or type a question in the chat. So this is a malignant squamous cell, and it's squamous because it's got very orangophilic cytoplasm compared to the other cells, which are more blue in color, and the nucleus is very abnormal looking. And then this is adenocarcinoma of the lung, where you've got larger cells with prominent nucleoli in the middle. You've got a lot of mitotic figures. So this is all malignant, and this is how a lung might look as it's received. And when we've opened it, the bronchus here, carina, and then you've got a large tumor there. And this is just an example of some of the different special stains that we might do in order to come to a diagnosis. Particularly FISH is used for breast cancer because we can do HER2 FISH testing, so fluorescence in situ hybridization. And this is chromogen in situ hybridization. So this one uses fluorescence to detect abnormal increase in copy number of chromosomes for the HER2. And this one uses a pigment, chromogen, to tag them. So normally they're tagged with different colors in order to see if they're amplified. And immunohistochemistry or immunocytochemistry can be used again for hormone receptors or for any other test that you might want to do to check to make the diagnosis or to check the organ of origin. And the other area that we have a role in is molecular testing. Now, whilst we may not do molecular testing in every single lab, we are kind of the gatekeepers of the tissue. So we need to be able to see what tissue is appropriate to send for molecular testing, because it's all very well taking a biopsy and just sending it straight for molecular testing. And I know there's a lot of argument about, well, not argument, but discussion about the future of cancer diagnosis and whether it'll all be circulating tumor cells or it'll be liquid biopsies where we just take the sample and send it straight to molecular. The issue with that is obviously if you take a biopsy and it's inadequate, or the tumor is only in a particular area, and then you send that whole sample for molecular testing, one, you may not get the right chromosomal abnormality pickup because you've got a lot of normal tissue in there, which could affect the result and ultimately what treatment that patient's on. So the pathologist's role is really also to gatekeep the tissue and make sure that the tissue, we've got enough tissue to do all the molecular tests. And this is where we sit within the MDT. So I don't know how many of you have managed to attend an MDT during your training, but I strongly advise it if you have the opportunity to attend an MDT in different specialties, so you get to know what the processes are. But essentially, you've got the different core members of the MDT, the coordinator, you've got surgeon or physician, oncologist, radiologist, and the histopathologist all involved, and specialist nurse as well. And there may be other members that are part of different specialist teams, but obviously those are the kind of core members for most MDTs. And it's an important part of the diagnostic pathway, and it's every patient with a cancer or suspected cancer has to go through a multidisciplinary team. And basically what happens is the patient gets discussed, their clinician says what they think, the radiologist says what they think of their images and maybe does some preoperative staging of the disease, and then they would have a biopsy, and then the histopathologist would give the definitive diagnosis, which would confirm the cancer type, the grade, and all the further prognostic information such as the nodal involvement and the size and lots of other factors. So the management really can't be decided until that information is there. And we also help to give prognostic information such as estrogen receptor and progesterone receptor and HER2 and various other prognostic tests. So Oncotype DX is a molecular test for breast cancer, PD-L1 and ALK, and these are all used for predominantly lung cancer, and mismatch repair is used for colorectal cancer, plus others. So yeah, so I would just emphasize what I've said earlier about being the gatekeeper. So moving on from that as to role of the pathologist, we're going to talk about grade and stage. So this is the question just to check, and if hopefully I can get that to work. Sorry, so yeah, so in terms of cancer pathology, what is meant by tumor grade? So got maybe just under half people voted. I don't know if anyone else wants to vote. Okay. So I think I'll end it there. So if we look at the results, so you can see a few people put these other aspects, but this is the correct answer. So how similar, so grade, so we're talking about tumor grade, how similar are the tumor cells to the cell of origin under the microscope? So grade is determined by a microscopic impression of the tumor. You're looking at how similar the cells look to what the original tissue was. And another word for that is differentiation. So if you have a low-grade tumor, you have a well-differentiated tumor. And if you have a high-grade tumor, you have a poorly differentiated tumor. So that gives you an idea about it. So I'm not saying that every tumor has 3 grades. Some tumors have 4 grades, and prostate has, Gleason pattern 3 to 5, and then combination can go up to Gleason grade 10. So the numbers are not so much, you shouldn't focus too much on the numbers, because the numbers can vary depending on what cancer you have, but most tumors have 3 grades, and the lowest grade, grade 1, well differentiated, and then a grade 3 being poorly differentiated. So I've got a question: do tumors metastasize to the areas that are similar to where they grew? E.g., does breast metastasize to bone because of the calcium supply? I think certain tumors have a propensity to spread in different ways. For example, breast cancer tends to spread to the lungs, the liver and bone. Prostate tends to spread to the bone predominantly. Thyroid cancer depends on the type of thyroid cancer. Follicular cancer tends to be blood-borne spread. Papillary thyroid cancer tends to be through lymphatics. So each type of cancer has a different propensity to spread. So I don't think it's quite that simple in terms of looking at what the where the organ is. It's basically, is it spreading through blood, lymphatics, and then local spread as well. So, oh, sorry. You've got the, so this is a histology section of a normal breast duct and lobule. So this is the duct here, and this is the lobule. And so this is where, the milk would be produced and then ejected through the duct. So there's a normal breast structure. You've got some fat here, these kind of white spaces, because the fat gets dissolved in processing. And then you've got some fibrotic area, which is just the stroma surrounding it. So have that in your mind when you look at the next picture, which is then a grade 1 breast cancer. And so you can see that the tumor is forming lots of tubules similar to these tubules here. Okay, and so that is that's a degree of differentiation. So seeing that means that this tumor is a low grade, because it's resembling its tumor, its tissue of origin. And then grade 2 tumor, yes, it looks like you're still getting tubules formed, but it's a bit more extensive in terms of it's a bit more solid. It's got bigger nuclei. There are other aspects here make it look worse. And then you compare that to grade 3, which has got a very solid appearance. It doesn't have any tubules really. It doesn't resemble the original tissue. So that's a poorly differentiated carcinoma. And then just going on to stage. So stage is, we're looking at tumor size, depth of invasion, nodal and distant metastases. So yes, TNM is part of staging, but you have the different numerical stages which people use. So, members of the public may say, I've got stage 4 lung cancer, or I've got stage 3, because that's what they've been told. But actually what it is it's based on the TNM combination. So for each, I'll go into this in a second, but for each tumor type, there's a different TNM combination which will give you the stage. So, but broadly, so stage 0 means it's in situ, it hasn't invaded locally, it hasn't become carcinoma as such, it's as in invasive carcinoma, it's still in situ. Stage 1 is where it's localized, it's not gone to nodes yet. Stage 2 is where it's early locally advanced, so it's gone to a few lymph nodes. And then stage 3 is where it's the tumor is very big and it's gone to lots of lymph nodes. And then stage 4 is where it's all of that, but also gone to the distant organs and metastasized. I'll just so there's a question: do the tumor ducts function like physiological ducts? No. So the tumor ducts, the tubules that are formed in the cancer, don't have the same function because they're cancers. The cells are not functioning normally. So no, that doesn't happen. So the report here. This is an example of a recent report that I did actually. You can see the date up there. And this is the type of report that we give in Harlow if someone's had breast cancer. So this lady's had a mastectomy, she's had a breast removed, and she's had chemotherapy prior to her surgery. So neoadjuvant chemotherapy, meaning before surgery, she's had chemotherapy. And the reason for that is because she's HER2 positive. And so HER2 positive tumors mean that that patient may be receptive to Herceptin therapy, which is given in order to shrink the tumor down, but also to improve survival. So if you can see so we take these images in the laboratory and we put them in the report. So you can see this is the mastectomy as it was. We ink it different colors because the surgeon has put sutures on it, and you might have seen that in theatre if you've been in theatre observing. And they put sutures on there in order so we can orientate the specimen, so we can confirm the side and confirm that it's definitely a left-sided specimen. But obviously we can't look at these sutures under the microscope. So the only way that we can transfer that information is to put inks. So we put different colored inks. We have red for superior, green for inferior. And so this is why the specimen looks like this, because we put inks on it. And we slice it into several slices so that we can see throughout the whole breast and have a look and see where we can see any lesion. But you can see here that this specimen was very dense and fibrotic. There wasn't like a discrete tumor lesion that was easily identifiable. And that can be because the tumor has completely gone after chemotherapy, although it does happen, but it doesn't happen that often. You get some response to therapy, but to have complete response where you don't have any tumor at all is relatively rare. And then this is the rest of my report. So I would say, so this lady has had a micropapillary carcinoma, which is a particularly aggressive type, which tends to go into the lymph nodes and into the vessels. So it has a higher risk of metastases. This is the grade, and then I comment on various different things because our Royal College have got specific things that we need to note in our reports so that the clinicians have the information they need. And then this gives you some information about the margins. So this is important. So the margins may dictate that the surgeon might want to go back or give, well, in case of mastectomy, no, but they might want to give additional radiotherapy to the area if the margin was close. Now, I appreciate you might not be able to read this that well, which is just to illustrate what all information a histopathologist gives in the process of cancer treatment. So, so there's important things here. You've got extensive lymphovascular invasion throughout the breast, so that's a poor prognostic factor. The hormone receptors here, and then talking about chemotherapy response, so there's some fibrosis related to the chemotherapy. And then the lymph nodes, we've got 5 out of 14, so quite a few lymph nodes are involved, and some of them are quite big deposits. So this is all information that the oncologist will need to decide what treatment they are going to have. And so this is the conclusion here with everything summarized. And you can see here that we also, this highlights the gatekeeper aspect, because we're telling, we're basically saying what block of tumor is appropriate for molecular testing. Moving on to TNM principles. So we'll just do the question. TNM stands for, and hopefully we'll be able to answer this from what I've said so far. Okay, a few more people. Anyone else going to vote? Seems to have stopped. Okay, let's shut that down. So that's the results there. So yeah, so the answer is tumor node metastasis. And yeah, so that's what that abbreviation stands for. And right, so talking about TNM now, so we've got tumor, which is looking at the size of tumor and the depth of invasion. Those two things are not always recorded for every single tumor type. For example, in breast cancer, the tumor size is the thing that determines the T bit of TNM. But in bowel cancer, the depth of invasion rather than the size is the thing that determines the TNM. So it depends on the tumor type and the origin. And you've got nodal metastases. So is there a nodal metastasis? How many nodes are involved and which region is affected? And these things will determine the end stage. But again, different things are significant in different tumor types. And then metastases, whether they've got metastases or not. So this is an example of colon cancer staging. So as I've said to you, depth of invasion is important for colonic cancer. So you've got the mucosal aspect, the submucosa, muscle, and serosa. So the staging, the T bit of the staging, is related to how far that tumor has invaded through the layers. So a tumor that's going into the submucosa would be T1, and a tumor going through the serosa through here would be a T4. And so that's why that's so. Yeah, so that's the arrangement for colonic cancer, but for other cancers it may be different. And then you can see here what I meant by this TNM combination indicating the stage. So you can have multiple TNM combinations, which might be the same stage. For example, stage 1 can be T1 or T2 disease, as long as it's not gone to the lymph nodes and not metastasized. And the minute it goes to the minute it metastasizes, it becomes a stage 4. And then the stages in between are various different combinations of T, N, and M. And this layout is there and present for every single tumor, every single site, organ site. And this is an example of breast. So you've got the tumor, the T bit of TNM is determined by the tumor size. So we look at 2 centimeters and 5 centimeters being the cutoff. And then number of nodes, and you can see here non-movable regional metastases, internal mammary nodes, so it depends where the lymph nodes are. So even if you had 1 lymph node in this area, that would upstage it. And you can see the different combinations there. And not every cancer has got 2A, 2B, 3A, B, C. Some of them might have just stage 1, 2A, 3B, you know, it may not have all of these. So I think you can't really, when you're trying to learn these things, you can't really try and, you know, even aim to memorize or even be expected to memorize all of the stage combinations for every single tumor type. What's important to understand is the principles of it. And I think I've just answered the question about do we have to learn individual TNM stages. So no, I mean, I think as pathologists, we do need to know the common cancers like breast, lung, colon, prostate. These ones we do need to know what the staging arrangement is for each one. But I think as an undergraduate, I think the main thing to understand is and not just undergraduate, also as a junior doctor who's not a pathologist, the main thing is to understand what TNM means, what the numbers relate to in the different tumor types, but not specifically be able to just reel out every single definition, because that's what these books are for. So we have the TNM classification of malignant tumors. We're in the 8th edition that we're using now. And this book is what we use to reference. So if I have a bladder cancer, for example, I would go to the book and say, and have a look and see which, what T stage and N stage that, that tumor is. And there's also the UICC website, which has various different staging classification information on it, which you can find. So this is the objectives of TNM. It's taken from the uicc.org website, talking about aiding treatment planning, which is probably the most important thing, providing an indication of prognosis, and then also the important thing, I think, is consistency. So you have lots of different cancer centers, different people making diagnoses and interpreting the radiology. The TNM enables a consistency of information, so that when I say this is a T2N1 M0 disease, then the other person will know exactly what I'm talking about. So it enables that facilitation of exchange, information exchange. And also contribute to, you know, the investigation of human cancers, because obviously we can record all this TNM data, but also, you know, we can record the TNM data and link it with molecular and other research aspects. So lots of these molecular tests, such as Oncotype DX, which was designed to give a recurrence score to see how likely is that tumor to recur, is based on various different pieces of information, such as TNM, to develop those tests. And it's also an important part of the cancer registry. So the cancer registry is a national database which records all the cancer-related outcomes, and that's TNM is a very important part of that. I think coming up to the last bit of the talk now. So just talking about the just the knowledge check to talk about. Hopefully you've grasped some of these pieces of information from my talk. So this is a question related to what I've spoken about. So stage 4 cancer implies the following. Got a few questions that have come up, so I'll try and answer them, but if we finish these up. So first is the degree of metastasis established using radiology or histopathology? Now, degree of metastasis. So if you like, the radiologist is seeing what the extent of the metastasis is. So they're saying, you know, this person's got metastatic disease, probable metastatic disease in the liver, the lungs, the bone. So straight away, the oncologist knows this person's got lots of disease. The pathologist is the one that's confirming that this is definitely metastatic disease. Because obviously, if you have a single deposit in the bone, for example, or in the lung, the radiologist may look at it and say, well, in the context of previous cancer, this looks worrying, but I can't say definitely this is cancer. A radiologist can only give an impression to say, I'm worried about this, this looks like it is cancer, but the pathologist is the one that gives the definitive answer. So they would take a biopsy of that, and then we would confirm that as being metastatic from the organ of origin. And so that's what so that's what we would do, and so we would confirm the metastases. And sometimes, let's say in breast cancer, a patient may have had estrogen receptor positive cancer, and then has metastatic disease, the oncologist may want to have a biopsy of the metastases so that we can repeat the estrogen receptor and the HER2 and other things to see if that has changed expression, and that might determine what treatment they need. So just ending this poll now. Yep, so we've got majority getting that correct. So yes, stage 4 cancer implies that it's spread to the distant organs, so as in it has metastasized, not to regional nodes. So that's the N bit. Okay. And then sorry, so that's that answer. And then the next one was so what information from the pathologist is required for management planning? And while you're voting on that, I'll try and answer the other question, which was, can you tell a bit about sentinel node, lymph node, and its importance? So I think, yeah, sentinel lymph node is basically, the principles of sentinel lymph node are that a tumor has some primary lymph nodes where it drains to. So the first lymph node that the tumor, or the area where the tumor is, drains to. And that's the basic idea, and that's what sentinel means. It's like this one standing guard, the one that's first to get the tumor cells. And so that means that if you sample those sentinel nodes, if they are negative, the chances are the remainder of the lymph nodes in that area are going to be negative. So it's a really important test, and it's used predominantly in breast cancer and melanoma, and not all types of melanoma, but pretty much most types of breast cancer get sentinel node. And the basic principles are that you have a radioisotope injection. So the patient comes in, they have their isotope injection into the breast or into the area where the lesion is, the tumor is, and then they have the procedure where they would have their lumpectomy, where they take the tumor out of the breast, but they also take lymph nodes out from the axilla. And during the operation, they use effectively a Geiger counter to check the radioactive level. They also inject some blue dye into the breast near to the tumor. So again, that helps to localize. So they use the Geiger counter plus the blue dye, and they try and find what the hot and blue node is. So the one that's got radioactivity higher level and also is blue. And they take that out plus some other nodes that also are blue. And then we look at them. Now, we in Harlow, we are one of the fewer centers that do interoperative molecular testing. We developed our own in-house molecular test called Metasin, which is used in our hospital, but plus another 3 other trusts in the country. And we developed that ourselves. And that's a molecular interoperative test where we mash up the node. We get the node fresh, we slice it, we mash it up, homogenize it, extract RNA from it, and do breast-specific markers, PCR on it, and that gives an intraoperative result within half an hour. That then goes to the surgeons, and they can then decide what they want to do with the rest of the lymph nodes in the axilla. So that's that. So I'll just end that poll. So yeah, so what information? Yes, so essentially it's all of the above. Yeah, so this is all part of your TNM. But margin status is really important, because if your margins are involved, you might need repeat surgery, you might need additional radiotherapy. And then you've got hormone receptor status, molecular status, which is also important. So these are all part of what we would give, what information we would give. And then so lastly, I think there's one more question. Yeah, so sorry, I think that's the last question. I think so the grade of tumor is defined by Yeah, so this again is just, so I think the really important thing is to understand the difference between grade and stage, because that's probably one of the most common things you get asked in terms of postgraduate exams. So, you know, it's a very common exam, for example, question, for example, in MRCS. I was a surgeon before I became a histopathologist, and that's quite a common question you get asked. And generally, I think it's important to understand it, because when I do teach even postgraduates, actually asking, you know, what grade of tumour is this, and then get back the other aspects of the tumour, rather than what it is. It means that they're not fully understood what the difference is, and it does make a difference. So I think you're probably polled out, I think, because so hopefully there's a few more people, but yeah, I think I'll end it there, because I appreciate we started a bit late, but hopefully they'll be able to answer some more questions. Yeah, so the grade of tumour is defined by the microscopic tumour cell differentiation. So differentiation meaning, do the tumour cells resemble the tissue of origin, and how close are they to that tissue of origin? So low grade being well differentiated, and high grade being poorly differentiated. So I think that comes to, so these are my takeaway messages. Again, I'll say grade microscopic tumour differentiation, how the cells look to the cell of origin. Stage is how much the tumour is spread. So with 1 to 4, it can be stage 0 if it's in situ. And stage 4 always indicates distant metastases, but it can be a different combination of TNM for different organs. Tumour node metastases, TNM, different definitions for each site, and the different combinations indicate the stage depending on where you are. And then, oh, sorry, let's, where should we come back? Hang on a second. Oh dear. Right, sorry about this. Right, sorry about that. So I was talking about TNM. So we've got yeah, the different definitions for each tumour site and the different combinations. And then the histopathologist role, so run through training after foundation completions, 5 years usually. And it's a shortage specialty, and it's a unique consultant-led specialty. So basically it means you have, you know, one-to-one, quite high level of supervision. You don't really do anything independently until you're a consultant and you've got your fellowship exam. So it means you get, you know, good quality training. The other aspect, which I haven't mentioned throughout all of this, is autopsies. So most people think of pathologists as the ones who do the autopsies. So yes, I do them, and I do post-mortems on a weekly basis, but actually the majority of my role is diagnosing the living. And I think that's a really important thing for particularly other doctors, medical students to understand, because the public perception of pathologists is very much forensic, silent witness, and you know, all we do is do post-mortems, and I think actually most general histopathologists, they are diagnosing the living the majority of the time, so that's an important thing to bear in mind. And we have an important role to play in the MDT to give all the tumour staging information and the biomarker status. So, and those things are all really important for prognosis and further treatment. So I think I shall finish that. So hopefully you will be able to scan this or use the link to give me some feedback, which would be very welcome, as this is my first session doing this for you. So the question, another question, in sentinel lymph node biopsy, you talked about looking at RNA. Why are you looking at RNA? It's just part of the assay because, you know, we're looking at tumor cells. So we're extracting the RNA from the node, and then we are looking at the RNA from, we're looking at breast-specific markers. So we're looking at CK19 mammoglobin and seeing whether those are present in the sample. So it needs to be a rapid amplification of, you know, a few cells potentially of tumor, and so that's the assay that we designed. So that's that. I'll just see if there's any other comments or anything else. Yeah, so that's the end of the talk. Thank you very much.